to be able to partake in this symposium to honour the retirement of Simon Hammond. The work that he did, as everybody has said this morning, has been of outstanding importance. I opened up the Bible of multiple sclerosis, McAlpine's textbook of multiple sclerosis the other day, and I noticed in the back that there are 6 first author publications of Simon's in the current issue, all in wonderful journals like Brain and Neurology and JNNP. And the fact that these are still there after 30 years of their publication is an outstanding achievement and shows how important the work was. I remember those days in the lab when Simon was completing his work, and there were whispers of incredulity that this man had produced such wonderful stuff, was leaving a future in academic neurology and going bush. But I and others didn't realise at the time, I think, a number of things, one being how uneven the health system in Australia is, how poorly many country towns are provided for in terms of specialist therapy. At the BMC in Sydney, we see quite a few MS patients and patients in large numbers from Canberra. If your GP in Canberra tells you that he thinks you've got MS, it takes a year for you to get an appointment to see a specialist, and that's completely unacceptable. But of course, that sort of problem would not have existed here in Orange with the wonderful group of neurologists that have been here. And of course, the other thing we never realised was what a beautiful place this is, Simon. This wonderful countryside, and it provides, I'm sure, a very wonderful lifestyle. Now, Simon Hawke has been very kind to me in giving me a topic that encourages me to look backwards rather than forward, and at my age I prefer to do that. And I thought I'd just have a nostalgic review of some of the studies that we partook in Jim's lab when I first started there in the late 1970s. I'll try and hurry through these slides because I noticed that we're about 15 minutes behind time. I think the reason that we thought that MS would respond to immunotherapy was because most of us believe that MS is an immune-mediated disease, and the strongest evidence towards that point is the pathology of the lesion, where there are perivascular round cells infiltrating into the tissue, and the lesions are almost identical to those that one sees in the animal models of autoimmunity such as EAE. And the second strong point is that there's an association of disease susceptibility genes involved in the autoimmune responses. When I first started in the lab, John Pollard was there focusing on the pathology of multiple sclerosis, and Graham Stewart and Jim McLeod were contributing some of the earlier studies on disease susceptibility genes. The pathology, of course, you're all familiar with. The perivenous demyelination that occurs in the acute lesions in association with the infiltration with T cells, B cells and macrophages. The chronic lesion in which there's limited remyelination and loss of oligodendrocytes, and that's something that Michael Barnett has contributed very importantly to in association with John Pollard in their landmark Annals paper. The gliotic areas which occur in the chronic phase occur in those particular regions of the brain that we are familiar with through looking at MRI scans, and that's a typical chronic plaque in a periventricular region. And if one takes a section from that and stains it with the myelin stain, such as the anti-MOG stain, there are these large patches of demyelinated tissue, and the higher power shows that they consist of numerous naked axons. Now, that plaque-like region of demyelination is characteristic of multiple sclerosis. It doesn't occur in the acute animal models. It doesn't occur in acute disseminated encephalomyelitis. I love these pictures of John's when he showed in the acute lesion the macrophages gobbling up the myelin from the myelinated fibres. Who really would doubt that this is an immune-mediated disease when you look at the intensity of those inflammatory infiltrates? And we now know, of course, that they're responsible for the breakdown of the blood-brain barrier, which gives us the gadolinium enhancement in our MRI scan. And in the slightly later lesion with oil red O stain, one can see the accumulation of macrophages filled with lipid, and there they are at higher power, infiltrating the tissue between the surviving myelinated fibres, and some of those show early remyelination. Now, when I first started in the lab, I began to focus on animal models of inflammatory demyelinating disease, mostly in the peripheral nervous system, but to some degree also in EAE. And people in this room like Sue Hodgkinson and Judy Spies did many of these studies. And we induced these animal models either with whole brain or nerve tissue, with T cells reactive to particular antigens or peptides to particular antigens. But in general, over many studies, we realised that chronic relapsing disease and plaque-like demyelination required whole tissue. You don't see it with just the peptides and the T cells. Those produce a lot of inflammation, but not much demyelination. But the morphology of the demyelination was similar in the PNS and in the CNS. Now that's a section from a nerve with someone with Guillain-Barré syndrome showing the perivenous demyelination, and the same picture one could see in an animal with EAN. And with the electron microscope you can see this perivenous demyelination, and John Prinius produced these lovely pictures of macrophages stripping the myelin from the Schwann cell and engulfing it, and here's a macrophage exiting the Schwann cell basal lamina, active in the association with this mononuclear cell, and finally one's left with a naked, sorry, seems to have stuck. Okay, so that's fine, thank you very much.
I'll leave it
but in the peripheral nervous system, we've actually found that the story is more complicated than just myelin, and we've come to believe that in fact there's an attack upon the myelin-producing Schwann cell, which is at the basis of this disease. Judy Spies did this lovely study showing a synergy between antibody and P2 reactive T cells in this animal model EAE. She produced EAN by active immunisation with whole myelin, all with P2 T cells, and then gave animals some demyelinating antibody systemically. And what we found is that the animals that just had the T cells got very mild disease. The animals who were so treated but had systemic antibody got much more severe disease. And the animals that had whole myelin disease had the same sort of disease, indicating that the synergy between antibody and T cells was reflected in the whole myelin induction that presumably activated both T and B cells. A nice picture from her study shows how the blood-nerve barrier becomes so leaky in animals given T cells here, and then perfused with horseradish peroxidase, but there was no leakage in the control animals. We then tried to ask the question as to whether one needed T cells of neuronal specificity, or would any active T cell do the same thing. And in this study we arranged for T cells to ovalbumin to accumulate in a nerve by a prior injection of a little bit of ovalbumin. And then we gave circulating antibody to the animals, and we found that there was marked the ovalbumin T cells and the antibody, but not in the control animals. So we conducted nerve conduction studies across that site, and as I said, the T cells accumulated there, although the cells were given intraperitoneally, because prior to that they were injected with a little bit of ovalbumin. And we were able to demonstrate that if you looked at the histology at 3 days, the T cells are beginning to accumulate in the nerve. There's a lot of perivenous inflammation at 5 days, but demyelination is seen only in those given systemic antibody, and even more demyelination is evident at later days as in the animals given antibody. We were able to show that the T cells actually breaking through the endothelial barrier in this way, and as they do so, they clearly damage that barrier, rendering it leaky. We did a similar study in the central nervous system. We injected little ovalbumin into the dorsal cord of the spinal cord. We gave the animals ovalbumin T cells, and we also gave animals anti-MOG antibody. We looked at the evoked potential by stimulating above and below the injection site and recording that response in the tail nerve. And we found once again marked suppression of the sensory evoked potential in the animals who were given the anti-MOG antibody, and we were able to see a large plaque-like area of demyelination in those injected animals, as one can see here. Here's a diagram of the area injected. Here's the time course of the conduction block, and here's the histology in the non-MOG animals showing T cells and no demyelination, but large areas of plaque-like demyelination in those given antibody. This is a similar thing in the eye, showing accumulation of T cells in the vein but not the artery. And this blue stain here represents the leakage of methylene blue into that area where the T cells are accumulating and being taken up by local macrophages. Now, in the peripheral nervous system, we recognise that nerve is not just compact myelin. There are these paranodal loops that attach in the paranodal area. There are the microvilli of the Schwann cells which attach in the nodal area. The node is a very complicated region. There are the sodium channels at the node, the potassium channels at the juxtaparanode, and between them these paranodal loops make a tight junction with neurophasin 155 joining to contactin on the axon, separating those two. And in fact, in this region there are numerous molecules that are being described over recent years, making this a very complicated region, but providing for us a number of possible targets for immune attack rather than just myelin. We used to look for antibodies in patients by looking at transverse sections of nerve, but of course that only shows you attachment to myelin. And these days we look at teased fibres where we can look at the region of the node, and we have demonstrated recently that there are patients who have antibodies in the paranodal region to neurophasin 155, others that have antibodies to contactin, so that Schwann cell targets are becoming the obvious cause of chronic inflammatory neuropathy in increasing numbers of patients. So the lessons that we've learnt from these models of inflammatory demyelinating disease are that T and B cell mechanisms are involved, that there are many targets of autoimmunity beyond compact myelin. There are therefore many possible targets of immunotherapy. And of course we need to keep remembering that MS is a chronic disease and it's not just a question of using sledgehammer therapy. Now, one of the first international trials in multiple sclerosis was mounted in Jim's lab back in the late 1970s and 1980. And this paper on transfer factor in the treatment of MS by Tony Baston, you'll note that it was a 2-year study that 60 patients were involved with relapsing remitting MS, and the patients were treated with transfer factor, which was an extract of leukocytes that were taken from cohabiting relatives of the MS patients. No one really knows what transfer factor consisted of, but I have no doubt that it contained a lot of cytokines like interferon and similar agents. The early studies were very promising, but the later studies didn't hold the same promise. The modern era of immunotherapy in MS, however, began with this paper by Hillel Panich. A small number of patients with relapsing remitting multiple sclerosis were treated for 4 weeks, twice a week, with varying doses of gamma interferon. In that short period of time, almost 50% of them had several relapses. As the authors say, gamma interferon is clearly not a drug that should be given to patients with multiple sclerosis, but on the contrary, drugs which antagonise its effect should be tried. And so began the era of the beta interferons, that being a drug which counteracts the effects of gamma interferon. Now, having watched the progress of MS therapy, I have been delighted that the treatment that's focused on just one element, the prevention of this chap getting from the endothelium into the central nervous system by an appropriate adhesion molecule in the form of Tysabri, has made such an enormous impact on this disease. There are many other targets, and I'm delighted to see that in addition to T-cell therapies, B-cell directed therapies are now being introduced, and maybe Sue Hodgkinson will tell us a bit about that later. Thank you very much.
So when Simon first asked me to give this talk, I was very pleased to accept, because although we've heard about Simon Hammond's great work in the epidemiology of MS, we haven't heard very much about his involvement on the evoked potential side. And at the time that he first started his project there, he did have occasional evenings where he wondered where he was going, and he wandered towards building number 92 at RPA, which is arrowed down there, and found me in a little black room doing evoked potentials. And we thought, why not do this in your MS patients? And so he took a little left-hand turn, and we actually did many productive works looking at evoked potentials at that stage, which were pre-MRI days, a very useful tool in the diagnosis of MS, initially with visual evoked responses with Martin Halliday and MacDonald, and then spreading to other areas, including motor, sensory and brainstem evoked responses. So his interest in this area goes back to that time, and we use some very primitive tools. And this is Simon and I. We haven't changed much. My moustache was larger than his at the time. So I'm going to talk a little bit about the application of evoked potentials in MS. So just leading into it, it's important to realise that although we talk about the mechanisms of pathology and immunology in MS, most of the symptoms are related to altered impulse generation and conduction in the central nervous system. And there are a number of different mechanisms that underlie this. There's demyelination, localised conduction block, frequency-dependent block, axonal damage, and this can be due to many different causes: inflammation, axonal transection, mitochondrial dysfunction. And this has effect on signal propagation and as such effects on the evoked response. And the most common finding is conduction slowing, which produces latency delay. You may have temporal dispersion of the volley, producing changes in morphology and amplitude. There may be increased refractory period and frequency-dependent block also affecting the amplitude. Or you can have straight conduction block reducing the amplitude, and you can have axonal loss reducing amplitude. So there are a number of different mechanisms of producing the underlying changes that we interpret as clinicians when we are doing evoked responses, and those changes include conduction delay, reduced amplitude, and dispersion or abnormality in the actual shape of the signal. Now, the classical monitor that we use, besides change in amplitude is quite variable, and in longitudinal analysis, amplitude is a difficult measure to use confidently, and latency, whereas is a very accurate measure. And Simon and I had looked at sort of test-retest variability of the change in the VP latency over time in normals, and it's within a few milliseconds over a number of years. So latency is an important measure, and then to interpret then what the meaning of that is an issue. So there's no question that there's a delay in the EPs, but is it a delay due to demyelination? And is the improvement of that delay secondary to remyelination? In the earlier studies, it was suggested by MacDonald that a demyelinating lesion in the optic nerve of 10 millimetres caused a conduction delay of about 25 milliseconds. This is something that's hard to prove, and I'll go into it a bit later, looking at how EPs can be used to help in understanding that pathophysiology. This is an example from Steve Jones showing evolution of conduction change in optic neuritis, and you can see over a number of months there's a marked delay in the P100 here. This is a normal right eye with a normal P100, and then a delayed P100 here at 3 months, and then a progressive shortening of P100 up to a 24-month period when stimulating the central field. So this is a typical evolution of optic neuritis VP, and I guess the question is that shortening due to remyelination, and then we'll talk about the potential applications of that knowledge. What are the roles of EPs? One can look at it in a number of ways. The role initially was a diagnostic biomarker. That role is a little bit less important these days, but in the 1980s it was a very important diagnostic biomarker of multiple sclerosis, a prognostic biomarker, a response biomarker, a disease progression biomarker, and then understanding pathophysiology by combining it with structural measures and functional measures such as tractography, MRI, OCT. The combination gives us an overall picture of how things are working, and gives us some insight into the mechanisms of pathology in MS. So one of the important things is that EPs have the capacity to detect subclinical lesions in pathways not well explored by routine MRI. So I'll go into that again in a bit more detail. So that's an important aspect of a diagnostic biomarker. And this is a typical plaque seen in the cervical cord, and SEPs show the classical abnormality with asymmetrical delay here seen on the side of the lesion. So this tibial evoked response, the P37, is quite markedly delayed, and the central conduction time is increased compared to the good side. And this is a typical finding that you might use to diagnose MS. And this is a median SEP, again showing the response from Erb's point, response from the spinal cord, showing a low amplitude and delayed N13, and then a delayed N19 P23 complex with increased central conduction time. And this is the sort of pattern that you see typically in MS. And this is another group of abnormalities here. You may see a delayed N20 latency with preserved spinal response. You may see an absent N13 with a preserved N20 response. You may see again an absent N13 and an absent N20 response. So you often see these patterns depending on the site of the lesion. And these are all very important and interesting when we were initially doing evoked responses to make the diagnosis in the setting of CT scans and no MRI scans, but less important today unless we're trying to differentiate other pathology. Now the classical patterns of abnormality in the visual evoked response, the first figure shows a normal VP with single channel P100. You can have an amplitude asymmetry, as you can see here, with some delay, just pure latency prolongation, or you may have a combination of both. Once you start doing half-field stimulation, I'll go into that in a second, you start to be able to differentiate it a bit more. This is a typical case of optic neuritis here with a swollen nerve and a delayed P100. And then if you go into a case with central scotoma, as evidenced here, you might see a pattern which is called the N105 pattern. So when you look at the left eye with optic neuritis, you see an intrusion of a negative component here, which is not there in the normal eye. And then when you do half-field stimulation, what you see is that there is actually no P100 in the appropriate half-field. What you're seeing is the N105 coming through, and sometimes you get a misdiagnosis of a delayed P100 being the P135. So these were the typical patterns seen in optic neuritis. Well, then you might have a retrochiasmatic pattern where you've got an optic radiation lesion, and we found, I think, about 12% of cases that we looked at with Simon and had a retrochiasmatic pattern in their evoked responses, where you see abnormalities in the half-field response. So this is a patient with left half field showing very poor response and a good response from the right half field, but hard to detect on the full field other than the fact that there's an abnormality in the shape of the potential. So the involvement of the retrochiasmatic pathways is actually not uncommon in MS, although clinical and VEP findings are not as common as they are pathologically. Over the years, motor evoked potentials came into the picture as well, and this is magnetic stimulation of the cortex in a patient with a pseudotumor MS lesion, showing a very abnormal response from recording from the right hand, from the right APB. And then this is some recovery 2 months later. So, and this is the classical brainstem evoked potential patterns with increased 1-3 interpeak latency, increased 3 to 5 interpeak latency, and 1-5 interpeak latency. So these were used diagnostically, but clearly the diagnostic purposes of EPs these days is not as important. When looking at, Keith Kappa looked at 26 clinical series encompassing 1,950 cases with EMS. These were the figures in terms of the sensitivity of the different techniques. So in cases of possible MS, 49% had abnormal SEPs, 37% abnormal VPs, and 30% abnormal BEARs. And when you got to definite MS, the numbers increased so that VPs were the most sensitive at 85% and SEPs at 77%, and brainstems were the least diagnostic. So this is an important column in that patients with no symptoms in the functional system had a high incidence of abnormalities, and particularly the SEPs and the VPs. And this is important in scenarios where you've got pathology in the cord, say, and nothing in the, and you're not sure about the brain, and you want to see if there's involvement, subclinical involvement, or you have abnormalities in the brain that are not particularly typical of MS. If you can show involvement of pathways that are not clinically affected, it is very useful. And this is looking at a study by Comey, showing the difference between symptomatic and asymptomatic patients. So in his study, in asymptomatic patients, up to 60% had abnormal VPs, and just slightly less than that abnormal SEPs, and considerably less than that abnormal bears. So they are still quite important in the setting of patients who have no symptoms in that particular area and may not have obvious lesions on an MRI in that particular area. If you want to show evidence of spatial involvement that's not evidenced clinically or MRI. So they still have a big role to play in that area. This is an example of what I was just saying. Abnormal spine, normal MRI, and normal spine and equivocal MRI. Now, one is able to also alter the classification of these patients from possible to probable to definite in up to 32% of patients in whom MRI did not change the diagnostic category. So if you used multimodality EP, so if you used motor evokes, visual evokes and somatosensory evokes, you could actually change the classification and be more confident as to whether they were probable possible or probable or definite in 32% of cases, and where the MRI did not change the diagnostic category. Furthermore, one can use the fellow eye in optic neuritis to correlate with the risk of MS. And it's a study that we looked at showing that if you looked at the latency in the fellow eye, the patients who had delayed visual evoked responses at presentation with optic neuritis were at greater risk of having MS at 12 months than the ones who had normal VEPs. And there's a number of possible explanations for that, not least of which is likely that this is due to retrochiasmatic pathology rather than due to subclinical optic nerve pathology. And so patients who present with optic neuritis in an isolated fashion are unlikely to have retrochiasmatic pathology, and therefore they're more likely to have a normal fellow eye VP. So the VP can be used in this setting to actually predict the development of MS in patients. And so this is showing that the risks, low risk, the latency is much shorter in the fellow eye in patients where they did not develop MS. In patients who went on to develop definite MS, the latency at presentation with optic neuritis of the fellow eye was considerably longer. The other area which we've just looked at, we just completed this study, is looking at using it to differentiate NMO and MS, where we looked at OCT and visual evoked responses and looked at rings, 5 rings of the retina, doing evoked responses from each ring using multifocal VEPs, and also measuring the ganglion cell layer and retinal nerve fibre layer in 5 rings. And what we showed was that there was a distinct difference in the pattern of involvement in NMO versus MS. That MS, not surprisingly, had severe involvement in the central retina, both on the ganglion cell layer and in the VP, whereas NMO had a diffuse involvement of the ganglion layer and of the VP. And what's been previously described, the involvement was more severe in NMO than in MS. What was also interesting was that in NMO, the OCT and VP were normal in the fellow eye, whereas there was a reduction in the GCL in the central rings and a delay in the VP latency as a group. So it's potentially allowing us to, if you have someone presenting with optic neuritis and they're antibody negative for NMO, and they don't have a long lesion in their spinal cord and you're not entirely sure, the pattern of involvement of the visual pathways as classified by OCT and VPs may help to differentiate this better. And we're looking at its application in MOG optic neuritis as well to see if somehow that has a slightly different pattern to MS. As a prognostic biomarker, there have been many studies, more than 1,000 patients and 13 different cohorts have shown a strong relationship between baseline multi-EP scores and future disability by EDSS. And this prognostic power is more pronounced in the early relapsing remitting phase and in primary progressive patients as compared to CIS. I won't bore you with all this, but EP scores are used, and so 0 is normal, 1 was abnormal latency or amplitude, 2 was abnormal latency and amplitude of a major component, and absence of a major component. And then they scored these in all the evoked responses and created a mean score and then did the analysis. And so this is Leo Carney's study showing a high correlation between these global EP scores and EDSS at the time. And this is showing another study looking at EDSS follow-up at 6 months, showing a correlation between the basal multiple EP scores and the EDSS at 6 months. So there's some capacity of the EPs, when looked at in a global fashion, to predict the severity of the disease and therefore predict where you're going to be in 6 months or 12 months. And with long-term follow-up, this prediction maintains. So there have been some studies looking at them up to 15 years, showing the correlation with disability at 15 years correlates very well with initial global scores of evoked responses. And you can also monitor progression of the disease in that way. So the relationship actually increases with the length of the observation period, and the change in the EP score over time may be used as a predictor of disease progression. It's important to note that upper limb SEPs may only be affected in the later stage, and lower limb SEPs may be absent, so you need to do both upper and lower limb SEPs, and the more EPs you do, the more accurate this observation is. So the other area is using EPs as a response biomarker. There's been a plethora of drugs now brought forward to look at promyelinating drugs, and a lot of these have included anticonvulsants, Lamictal, Dilantin, and more recently the anti-lingo drugs. Now, it's also been shown that drugs like formominapyridine can produce a symptomatic effect, and there have been MEP studies showing that patients who do get an improvement with fampridine are the ones that actually have shortening of their MEP latencies in the appropriate limb. So it can be used as a response biomarker. And this is a study, an old study, looking at the effects of azathioprine and steroids on the VP. Mark Newer did the study in 1997, showing that the VP became considerably worse in patients on placebo and azathioprine, but the combination of azathioprine and steroids led to a maintenance of VP latency and SEP latency. So it was useful as a biomarker. The anti-lingo study that we were involved in used the optic neuritis model, used OCT and multifocal as well as conventional VPs, and there was some positive data at 3 months showing an improvement in the VP latency in the group that were treated with anti-lingo as compared to the group that weren't. The other, I thought, more interesting finding, which was only seen by the multifocal VPs, was that the fellow eye amplitude increased, suggesting the potential explanation is that, as we mentioned earlier, the fellow eye latency changes may be due to retrochiasmatic pathology, and that the amplitude may have improved because anti-lingo worked not only at the level of the optic nerve, improving the optic neuritis that had occurred and remyelination, but it might have occurred in improving chronic demyelination in the retrochiasmatic pathways. That's sort of study. They're extending that study to more general MS, and it'll be interesting to see if it proves to be effective. But it's certainly proof of concept that VEPs and OCT in combination can be used as a model of using new drugs to treat or promote myelination. And this is just a simple diagram showing changes in EPs with disease progression in a primary progressive patient, showing marked deterioration over time. So EPs can be used as a biomarker of disease progression. Now finally, pathophysiology. It can help us understand mechanisms of demyelination and remyelination, and this is a study showing that we looking at latency delay which correlated with lesion length. What we found was there was a very nice correlation with the length of the optic nerve lesion. This is a long lesion showing an average latency delay of 25 milliseconds and a short lesion with an average latency delay of 14 milliseconds. And when you look at the graphs, both at the time of optic neuritis and then 12 months later, there's a good correlation between lesion length and latency delay, and this was maintained at 12 months, even though the lesion became shorter and the latency became shorter. So it would suggest that latency delay is probably related to remyelination. This is another study looking at the evolution of latency, and you can see that the most severe delay is at 1 month. The greatest rate of recovery is between 2 to 3 months, and then there's a slow recovery between 6 and 12 months, so it sort of plateaus. And so this is the window of opportunity for remyelination, and the VP demonstrates it quite nicely. So the conclusions are that the gradual shortening of the latency is most prominent in the first 3 months, and the relative improvement in the latency is less in longer lesions, suggesting a window of opportunity that is gone after 3 months, so that if your oligodendrocytes can actually get there within that window, it can promote the remyelination, and it supports that mechanism. I'll quickly go past that slide. Now, the other area is looking at other mechanisms of injury in MS, and this is where we found that axonal loss in non-optic neuritis eyes of patients with MS were linked with the VP, so that the OCT in the non-optic neuritis eye of MS patients had reduced RNFL, and it correlated with the delay in latency. And you can see quite nicely here that there was a VP delay in non-optic neuritis eyes, and it was symmetrical, so both eyes were delayed. So patients without optic neuritis had delay, and when it was delayed in both eyes, and there was a correlation between the RNFL and the VP latency. So the implication of this is that the pathology is retrochiasmatic. So the delay in the fellow eye and the subclinical delay in both eyes in patients who haven't had optic neuritis, it's probably retrochiasmatic. And we looked at correlating that with the MRI lesion load, and there was a high correlation with MRI lesion load and the radial diffusivity in the DTI. And so the implication is so I'll move on to the next slide. The implication is that the high incidence of delay in the non-optic neuritis eye and the correlation with RNFL and optic radiation lesion load is due to retrochiasmatic pathology and may support transsynaptic degeneration. And so using VPs and OCT and MRI in combination, we were able to support the concept of transsynaptic degeneration, which might be important in progression of MS and leading into the secondary progressive phase. So EPs can be used in both diagnostic purposes, in prognosticating, in developing, assessing disease severity. The application using things like the optic neuritis model in the development of pro-myelinating treatments, and in understanding pathophysiology in combination with scans and OCT. And probably, you know, to get NIDA, we're going to have the NIDA concept that we talked about. We're going to have NIDA with MRI, with OCT, and with evoked potential, so as well as clinical findings. So people are going to be controlled to the point of functional as well as structural as well as clinical levels. So I'll leave it at that point.
Thank you, Con. Are there any questions? Sue?
Con, do you find this contralateral involvement at times, even in very early cases where you haven't got very extensive disease? Because all those pictures you had were people with quite a lot of disease where you could envisage there's synaptic transfer. But I wondered whether there could be subpial involvement along the optic nerve that you can't see on the MR, on the normal optic nerve.
Well, look, it's certainly possible that some of those cases, I'm not saying that all of these cases could be retrochiasmatic. I think some of them probably are optic nerve involvement that's subclinical. But the finding that makes you think at least a significant proportion of them are retrochiasmatic is that the ones that haven't had optic neuritis have symmetrical involvement, so that both VPs are usually delayed, and if you correlate, they correlate with each other. That would suggest that it's probably retrochiasmatic.
Michael?
Sorry, comment and question. Comment to your question. In a modern clinical trial cohort, i.e. one in the last 3 years, we found about 70% of patients have optic radiation lesions, so it's really common. The question, Guy, you talked about the window of opportunity for remyelination. Do you therefore discount the possibility that chronically demyelinated axons can be remyelinated if we have efficient enough therapy?
Well, I don't, and I think that the anti-LINGO trial would suggest that's probably not the case, because the improvement in the amplitude of the fellow eye would probably argue that that's due to helping remyelination in chronically demyelinated lesions in the optic radiation. So I suspect not, but I think that in acute lesions like that there is that process, that acute remyelinating process. There is a window of opportunity, but I'm not a pathologist or immunologist, but I get that is the case. I don't know.
And one last thing, sorry, Judy. This is great in the sense that it's going to produce a biomarker potentially of remyelination. How are we going to convince regulators to accept a biomarker for a therapy that works based on these outcomes but doesn't have an immediate clinical effect? In other words, there might be a therapeutic lag because you're protecting these axons from dying over the next 10 years.
Yeah, that's a good point, Michael. That's the challenge, because I think that part of the problem, even say with the transfer factor trial, is that we're basing all these things on clinical outcomes, and we need to convince authorities that biomarkers that tell us that we're actually doing it, but we might not see the clinical effects for some time, are important. But it's a challenge that's really important to address.
Okay, we might move on to the next speaker then, and she's going to tell us about MS as an autoimmune disease.
Okay, I'd like to thank Simon Hawke first for the invitation to speak at this fantastic event in Simon Hammond's honour. It's a real pleasure to be back here as one of the first group of trainees who had the pleasure and the great fortune to do some of their training in Orange. It's really lovely to be back. And it's a real honour to speak amongst all these very expert speakers, in fact. So I've been asked to speak about MS as an autoimmune disease in terms of current concepts. So I will very briefly talk about some of those early evidences for autoimmunity, but they have been already beautifully covered by Professor Pollard, so we'll make that quite brief, but just use it as a platform to talk about our evolving understanding and evolving concepts in MS immunopathology. And then, time permitting, I've just picked two areas in MS immunology where there's been some sort of novel developments of late to just cover briefly. And those are the gut and MS, and a little about the ins and outs of the CNS. So I don't think there'll be much new on this slide for this audience here. As we've already heard and seen beautifully presented, histopathology is one of our greatest sources of evidence for the role of the immune system in MS. And also, really early in our understanding of MS as a condition, it was noted that there's an excess synthesis of immunoglobulins in the CSF. And of course, CSF oligoclonal bands have been a cornerstone of our diagnostic workup in MS for many years, and they seem to be coming back into fashion, in fact. As we heard at ECTRIMS last month, they're making a reappearance in the next edition of the McDonald criteria for diagnosis, which is interesting. We've also heard mentioned our evidences from genetic studies, starting with linkage studies and then more recently GWAS studies, which show the majority of genes we know to be associated with MS susceptibility are actually immune system related. We've also heard a little about our somewhat imperfect animal model of MS, which is EAE, and we know this is caused by myelin reactive T cells causing CNS damage. And finally as well, obviously the great efficacy of our early immunomodulatory agents was nice early evidence of the role of the immune system. So this sort of diagram has already been seen as well, and I just want to use it to point out a couple of our early concepts in MS immunopathology, those being that the T cell is a major player, that it's activated here in the periphery by an antigen presenting cell presenting its antigen with co-stimulation, that it goes through a number of complicated steps to get through the usually tight blood-brain barrier, and then once in the CNS, it is reactivated by seeing its antigen presented by an APC and goes on to release inflammatory mediators that cause damage. So if we start from that, T cells, and in particular CD4 T cells entering the CNS and causing disease, the first question is, why do we focus on CD4 T cells? Traditional EAE models were CD4 T cell based, although it's worth saying there are very similar models using myelin reactive CD8 T cells. Again, from genetics, the HLA locus, in particular, the HLA class 2 alleles are those that are most strongly associated with increased MS risk. And again, if you move forward to the GWAS studies, it is the CD4 T helper cell differentiation and activation genes which are really overrepresented in the MS susceptibility genes. And while I'm mentioning T helper cell differentiation, it's worth just briefly mentioning historically when we first divided T helper cells into Th1 and Th2, it was felt for various reasons, mainly related to EAE, that MS would be a Th1 mediated autoimmune disease. But even early on, I think it was pretty clear that it couldn't be the be-all and end-all. And then once there was a discovery of the importance of the IL-17 cytokine and the Th17 subset of cells, there was some shift in the focus of MS immunology research towards it perhaps being a Th17-driven disease. I think failures in MS therapeutics have taught us a lot in terms of immunology, and one that's worth pointing out at this point is an interesting failure of a monoclonal antibody to IL-12 and IL-23. That's interesting because IL-12 is the primary driver of Th1 responses, while IL-23 is the primary driver of Th17 responses. So targeting both these cell groups that we thought were the be-all and end-all actually failed in MS. And that's a clue to the role of other portions of the immune system. I mentioned a lot about effector cells, so I just want to mention that we have known also for a very long time that the regulatory CD4 cells are abnormal in our MS patients. If not reduced in number, they do seem to be a little bit impaired in their suppressive capacities. So while we're on CD4 T cells, I want to say there has been expanding work even within CD4 T cells, broadening our scope of what cell subsets might be important in MS. And I'll just point out one of these as an example, and those are GM-CSF expressing CD4 cells. So GM-CSF is a pro-inflammatory cytokine, acts particularly on myeloid cells. It can be, as you see in this flow plot, co-expressed with interferon gamma, but it's also expressed by another more unique subset of CD4 T cells. And in a number of studies, and the one demonstrated here, GM-CSF expressing CD4 cells may be increased in MS patients. They may be higher in untreated versus treated patients. And most interestingly, perhaps they may associate with markers of disease activity. So here being higher in patients accumulating more new lesions on MRI. So that's one example on the effector side. What about regulatory subsets? And there's been lots of work and much functional subsetting and work on different expression of different suppressive molecules on Tregs that I will not bore you with, but I'll give you one example of one of these sorts of subsets or molecules, and that's CD39 expressing regulatory T cells. So if you look at this flow plot, which is plotted on our traditional FOXP3 positive regulatory T cells, it's shown in a number of studies that about 50% of these cells express CD39. What's interesting is that that specific subset, again, may be reduced in relapsing MS patients. And most interestingly, while both CD39 positive and negative cells could suppress Th1 cells in this study, it was only the CD39 positive that could actually suppress Th17 cells, saying perhaps this subset is relevant. But I want to move past CD4 cells and say that it's been some years now that there has been a renewed interest in the role of CD8 cells in MS. If we go back a long way again to histopathology, previous histopathology, we've known for a long time that CD8 cells actually outnumber CD4 cells in our MS lesions. And they're not just drawn there in a bystander fashion by inflammation, but they're actually clonally expanded, meaning that they are responding to a specific antigen. Much like CD4 cells, we've subset these CD8 effector cells into many specific subsets, TC1 expressing interferon gamma, TC17 expressing IL-17. And these cells are found in lesions and in the blood and CSF of MS patients. And again, similar to the CD4 side, we have GM-CSF expressing CD8 cells, which may be increased in the blood of MS patients. I'll mention one other subset because it has received a little bit of research interest of late, and those are the mucosal-associated invariant T cells, or mite cells. They produce IL-17. They're named because they're found prominently in the gut, which is another buzzword or interest area. And they express this invariant V-alpha 7.2 T cell receptor chain. So here you can see staining for these cells in CNS lesions, and it turns out you can, in some studies, find these in quite high numbers in MS lesions. However, their levels in the blood in relapsing patients have been somewhat contradictory in different studies, and their role, whether it really be pro-inflammatory or in fact more tolerogenic, is yet to be fully determined. Again, it's one theme here. I've spoken about effectors. I will mention regulators. There are regulatory CD8 T cell subsets that we're understanding more about, and early studies such as this example suggest that they too may be dysfunctional in MS patients. So this study showed, particularly in patients having relapse but not in remission, that the frequency of CD8 regulatory cells was decreased. So if we go back here, we started with T cells, CD4 T cells, effectors and regulators having a role in the pathogenesis. We have to add the importance of CD8 cells, both effectors and regulators, but we need to move beyond T cells. And I want to spend just a couple of slides talking about myeloid cells. They're not usually getting perhaps quite as much attention as the other lymphocyte subsets, but we've known from histology that they have a clear role for a very long time. They're a very abundant cell type within MS lesions. And I'll mention here that when I say myeloid cells, I'm referring to both activated resident microglia and infiltrating macrophages. And that's partially because they're very difficult to tell apart on histology or immunocytochemistry. That might be important actually because they have been implicated in both positive and negative roles in MS, and it's unclear what cell type is doing exactly what. So on the negative side, they've been implicated in demyelination, and they certainly can release a number of molecules that are detrimental to neurons. On the other side, they clear myelin debris, they can promote remyelination, and they can also release neurotrophic factors. So much like other immune cells, they have been subset into functional subsets. So the main ones being pro-inflammatory M1 cells, and they are, for example, driven towards an M1 phenotype under the influence of cytokines like GM-CSF. And these M1 cells can release pro-inflammatory cytokines. And the other major subgroup is the anti-inflammatory M2 subset, which are more phagocytic and can release anti-inflammatory cytokines. So it's been noted often that, and as you can see in this inset here, that myeloid cells are often in close apposition to lymphocytes in MS lesions, and it's very conceivable that they're having important cross-communication and cross-interactions. Already from what I've told you, the cytokines that they release could influence the T cells around them. And also their clear role as antigen-presenting cells and presenting co-stimulation or co-inhibition signals may be relevant. Myeloid cells have never been the specific target of our disease-modifying therapies, but nonetheless our broad immunomodulators do change their phenotype, and for a number of them it's been shown to push them towards an M2 phenotype. Finally, even if you move away from areas of lesions in the brain, areas where there's no demyelination, no axonal loss, we know that there's increased numbers of activated microglia even early in the course of MS. And we don't know the full significance of this, whether these are pre-lesional areas or what the exact order of events is, but it's clear that's something that should be worked out. So if we go back to this diagram, myeloid cells are clearly important in the CNS. They can be divided into good guys and bad guys, if you like, and there's important cross-communication with T cells. I'll move on now to probably the most topical of the immune subsets, the B cells. Again, going back historically, we've known that they're there. We know about the increased immunoglobulin in the CSF. We see the B cells, the immunoglobulin and the complement in the lesions, but perhaps one of the major reasons for the more renewed interest in their possible role in MS has of course been the impressive efficacy of B cell depleting agents in treating relapsing MS and some early data in primary MS. An example here shown just from the OPERA trial of ocrelizumab, showing a 95% reduction in gadolinium-enhancing lesions with ocrelizumab compared to active comparator interferon, and they had about a 50% reduction in relapse rates on that study. And we're going to hear more about B cells later. I'm not going to harp on about them, but I will mention a couple of things to keep in mind when we're talking about the role of B cells, and that's that not only are stem cells spared by these therapies, but so are the antibody-producing plasma cells. And indeed, if you look at the CSF levels of immunoglobulin in these patients after they've been treated, the immunoglobulin levels are not affected. So this points to another role of B cells, or another way in which these therapies are working through B cells. Another area where B cells have gained more attention is in the finding of these meningeal follicle-like structures. This has been predominantly in SBMS cases and in a number of series, autopsy series. They've been shown to perhaps be present in up to 40% of SBMS cases. So looking at them, you see in the meninges here a dense cellular infiltrate. It's staining heavily for CD20, so those are the B cells. There's also T cells and dendritic cells in these follicles. And interestingly, when they're stained, I'm not sure you can see that in this light, but this is a proliferation marker Chi67. That's positive, suggesting that the B cells are undergoing proliferation in these follicles, suggesting perhaps they're forming germinal centre-like follicles. What's the relevance otherwise? There has been some association made in these studies with areas where follicles are, shown in this picture with the little yellow spots, with increased underlying cortical demyelination and other markers of disease severity. As well, and perhaps more interestingly, there's some association in this study with patients who are follicle positive, shown in red, versus those who are follicle negative in green, having a more accelerated disease course. So those who had follicles had earlier onset of disease, more rapid progression to death. So it's not clear cut. These follicles haven't been found in every series. They're difficult to find, and it remains somewhat controversial. But another pointer into B cells' role. So B cells, we now know well, can release pro and anti-inflammatory cytokines that can affect the cells around them. So as an example, on the anti-inflammatory side, B cells can make IL-10. I'm sorry, the labels have come off here, but the MS is black and healthy controls in white on that one. And here's just two example studies, each showing that MS patients' B cells make less IL-10, or that there are less IL-10 producing B cells in MS patients versus healthy controls. On the other hand, B cells can make pro-inflammatory cytokines, including some of them shown here, GM-CSF, TNF-alpha, lymphotoxin. And again, there have been studies suggesting that in MS patients, there are more of these pro-inflammatory cytokine-producing B cells. So, just to spell it out, although we've pretty much said it, we now realise that there's multiple functions of B cells, that we no longer consider them just cells that differentiate into plasma cells and make antibodies, but they have this range of antibody-independent actions. The release of these cytokines, pro and anti-inflammatory, can affect the phenotypes and the function of T cells and myeloid cells. And obviously they're effective antigen-presenting cells and can present co-stimulation or inhibitory signals to T cells. So I just want to take a couple of small examples to show why this sort of B cell modulation of other immune cell subsets may actually be relevant in MS. So the first, and if you just focus on this part of the graph for simplicity, is a study looking at patients treated with rituximab and looking at their their myeloid cells pre and post treatment. So if you look at their myeloid cells pre and post treatment and the level of production of a pro-inflammatory cytokine IL-6, just taking away their B cells, not specifically affecting their myeloid cells, reduces pro-inflammatory cytokine release from their myeloid cells. Similarly, and by the same group, if you look again pre and post rituximab at these patients' T cells, their T cells, both CD4 and CD8, proliferate less and make less interferon gamma and less IL-17 just by virtue of having taken away their B cells. So it really seems that these may be relevant in pathogenesis and how these drugs we're using may be working. So if we go back to my favourite diagram here, B cells are clearly important in the CNS. You can divide them into regulators and effectors again, like the other subsets, and they have clear bidirectional communication with T cells and myeloid cells. I think the immune system is really all about complex interplay, and I don't think you're going to get away without every immune cell being somehow involved. And so perhaps in the future you should need to add cells like NK cells into here. We already know NK cells have regulatory and cytotoxic type subsets. And there's been a suggestion that one of the medications that we now have available, daclizumab, has its action in MS through expanding this regulatory subset of NK cells, the CD56 bright cells. And we know that those type of cells can modulate effector T cell reactions. So, that's sort of a question mark. But I think the real overall message here is that it's a matter of complex interactions between our immune cells and perhaps the overall immune balance, and if you want to call it between regulators and effectors, that's actually important in creating disease. So with my remaining time, I just want to mention those couple of other areas where there's been some novel research findings. And the first is the microbiome, which has been mentioned already today as a sort of a buzz topic, and it's certainly getting interest in neurological disease as in other diseases. You can see the rate of publications related to it increasing over time. So in brief, we have over 100 trillion microbes in our gastrointestinal system. You would all know or infer that many factors, often and perhaps just by coincidence, overlapping with MS risk factors, many factors can influence the composition of the microbiome. Genetics, age, diet, smoking, obesity, as we've mentioned as well. We've known we've evolved with the microbiome and that it's necessary for normal metabolism for a long time, but it's more come to light that it's actually critical in both the development of our immune system and in its ongoing normal function. So leaving these aside and focusing on autoimmunity, there has been a specific role proposed for the microbiome in effector T cell development, particularly the development of Th17 and T regulatory cells. So what's the actual evidence in MS? Well, there's not a lot in MS that I'm aware of, but there is some interesting observations in EAE which are worth a quick look. So in this study, they had spontaneous EAE mice who were raised either germ-free or in control conditions, if you like. You can see that the germ-free mice develop spontaneous EAE at an extremely reduced rate compared to those who have the normal microbiome. And moreover, if you take the microbiome from these mice here and transplant it into the germ-free mice, they start developing EAE at the expected rate. Similar sort of concept, if you take spontaneous EAE mice and you treat them with antibiotics, you can ameliorate the EAE even after its onset here. And importantly, here, this only works with oral antibiotics. So if you give these mice intraperitoneal antibiotics, it doesn't do the same thing, suggesting it has got to do with gut microbiome. And in that same study, they looked at these mice, the T cells from these mice, and found that those that received oral antibiotics, their T cells actually make less interferon gamma, IL-17, and more IL-10, proposing a possible role there. What about MS patients? This is the same study, actually, the Japanese study that was, some of the data was presented earlier, just to make the point that there has been a number of studies in different regions and including paediatric MS patients to suggest subtle differences in the composition of the microbiome between healthy controls and MS patients. They've not been the same in different regions, and you could imagine the reasons behind that. This was an interesting study I thought was worth highlighting as well, which actually used twins who were discordant for MS diagnosis. And they took the microbiome from the twins and transplanted them again into spontaneous EAE mice. So you can see that the unfortunate mice who received the microbiome from the MS patients developed their spontaneous EAE at a much greater rate than those who received the healthy twins microbiome. Of course, the twin benefit is that you're going to take away some of the variation in genetics and diet and region and the rest. So that's sort of interesting. And again, if you look at the T cells from these mice, firstly, the MS recipient mice, if you like, made slightly less IL-17, which was a bit of a surprise, but somewhat more markedly less IL-10. And this paper went on to do a little bit more work to suggest that IL-10 might be important. I have one slide just to say not to forget worms, because they're also very topical. We've known for a long time in medicine that parasitic infections push the immune system towards a Th2 response. And the interest in helminth infections in autoimmunity is increasing. There's not a lot of work that I'm really aware of in MS, but I just thought I'd show you this interesting small study. So this is an unblinded small study. They found 12 patients who had 12 MS patients from a bigger cohort who had parasitic infections and also had eosinophilia. And they picked 12 then matching controls, and they followed them actually for for a few years. And it's observational, it's unblinded, but the patients who were infected with parasites had very few exacerbations, no change in their EDSS, and minimal change in MRI markers of disease activity compared to the uninfected. So that's really just to watch this space because it is of interest. The final little topic, if I have 3 more minutes, is just to mention another interest area, and Professor Pollard also mentioned the importance of lymphocyte trafficking and how are these immune cells getting in and out of the CNS. So we've known for a long time, the blood-brain barrier is important and the blood-CSF barrier is another portal of entry. We know a bit about how cells get in through the blood-brain barrier. We know that T cells, for example, upregulate multiple molecules that help them cross the blood-brain barrier and damage the blood-brain barrier, as we've heard, including adhesion molecules and integrins. I'll mention that we don't know as well for B-cell trafficking, but that a lot of the molecules do overlap. And we know that targeting CNS migration, say by sequestering T cells with fingolimod or targeting the actual transmigration with natalizumab, are very effective therapeutic mechanisms for MS. What I want to say is that the process here appears much more complicated than first thought, and that's shown in this diagram or even listed with these molecules here. And there appears to be multiple possible adhesion molecules that may help lymphocytes cross the blood-brain barrier. And just as one little example of that, this interesting study looked at long-term natalizumab-treated patients and looked at their T cells and actually found upregulation of this, I don't know if you can see it, this other adhesion molecule that is on this diagram, PSGL1, and increased use of MCAM and PSGL1 to actually cross the blood-brain barrier. So, there may be other targets here and other important targets if we want to selectively stop cells getting into the CNS. The other major advance in this area has been the overturning of this long-held belief that part of its immune privilege is that the CNS doesn't have lymphatic drainage. So this seminal paper, work done in rodents by the Kipnis group in 2015, they were able to show that small vessels that structurally look like lymphatics are lining the cerebral venous sinuses in these rodents, and they were able to show that these lymphatic vessels transport lymphocytes and matter that was injected into the CSF, for example. And they did some early work just to say that similar structures might exist in humans, but really hot off the presses, published just a month ago by Danny Reich's imaging group, they were able to very nicely use 2 kinds of gadolinium-based contrast, one that leaks into lymphatics and one that doesn't. And here, showing on T2 flare imaging, use a subtraction technique to actually nicely highlight these tiny vessels lining the cerebral venous sinuses, just as was predicted and shown in the mouse work earlier. So this is quite an area of interest. Dr. Kipnis, in fact, mentioned some work in his talk in ECTRIMS last month, although it's not yet published, to say, again, in EAE, they found if they stop CNS lymphatic drainage that you can ameliorate EAE. So I think this is an area that's going to be a lot more press, and it's led to hypotheses such as this one, that we already know from other studies that B cells traffic bidirectionally in and out of the CNS. So perhaps B cells carrying CNS antigen are exiting via these lymphatics to the deep cervical lymph nodes, presenting antigen to T cells who can then re-enter, and perhaps that's one of the ways in which relapses are triggered in MS. So I think we need to update these portals of entry and exit that we think about in our research. So not only the blood-brain barrier here and the blood-CSF barrier here, but what's the role of these dural lymphatic vessels and their drainage to deep cervical lymph nodes. So with that, I'll just conclude with a few statements. So I think it's becoming more clear that it's really an interplay between immune cell types and perhaps the overall balance and flavour, regulatory or pro-inflammatory of the immune system that's important in immunopathology in MS. This is just an interest area, but maybe we'll figure out that the gut's an important area of peripheral immune modulation. We know that definitely immune cell trafficking is a critical step in MS and a definite effective therapeutic target. And finally, when we look across MS immunology studies, you see a wide range of differing immunological disturbances shown in different groups. Perhaps these heterogeneous findings suggest that we're actually dealing with more than one simple condition. But the other thing it means is that we have many potential therapeutic targets, and it opens the door that perhaps in the future we can actually personalise our immune therapy to patients and their immunopathology. So with that, I'd like to say it's really lovely to be back in Orange, and thank you again.
Thank you, Mahtab. Fantastic overview. Any other questions? Michael?
That was a really great talk. Beautiful overview. It's just a question about the follicle positive and follicle negative.
Yeah.
Why is it not just that the follicles are secondary to the subpial demyelination, given that we find it in those patients and that we know an MS lesion deeper in the parenchyma is associated with infiltrates of T cells, B cells?
Yeah. No, it could be. Association's not causation, and the direction of those findings is not yet shown, and as I said, it's still very contentious. So they would need to be shown earlier in disease, not just in autopsy specimens of advanced secondary progressive patients before you could suggest what they're suggesting, which is perhaps from these follicles going the other way, there's release of mediators and things which are diffusing downwards and causing this. That's not proven.
Which would be more in keeping with Andrew Henderson's work about infiltrates of those cells becoming parenchymal lesions much more prominent later on in the formation of the lesion.
Yeah, okay. Thank you.
Dr. Rubens?
Just a question about the disparity of male females with MS. So women having a high propensity for MS, relapse remitting form. What's known about estrogen B cell sort of interactions, and that then leads into the whole pregnancy issue, what's happening to the immune system and the protective effect of the last trimester with that interaction. So do you want to make any overall comment?
I'm probably not expert enough in that area. It's a key observation in MS, and then clearly we should be able to look into what is the immunological association and hormonal association that's underlying it, but I wouldn't be able to answer that for you in a succinct way. Yeah.
This is a totally anecdotal statement, but I had a patient who saw a gastroenterologist in Sydney who was prone to fecal transplant. not the doctor, but prone to giving fecal transplants. I think it was his mother's. He was having recurrent attacks, and actually his MS was progressing not well. And he decided to leave me and go and see this fellow, and then didn't come to see me again for years. He stopped all his treatment, and then I followed him up now for 15 years. And his MS is totally stable since that time on no treatment. There was an interesting case similar to that, presented at ECTRIMS. I mean, it's totally anecdotal, but I'm not proposing fecal transplant. but
yeah, it's an interesting area, isn't it? I think so.
Jamie?
A case of which that was a female. I've got a fellow with MS who's been treated with Wasabi from the start. And he's undergone gender realignment therapy to become a woman. And the extraordinary thing is that his MS symptoms have improved dramatically. to the point where his
Interesting.
marijuana use is minimal, whereas it was daily, multiple times a day.
Sounds like a good case report. That's really, really interesting.
Yeah, that's a statement.
Thank you.
Thanks again, Mahtab.
That's also very good. So I've been given this remit of discussing current MS therapies, which seems to be a broad topic for half an hour and 1 year in the MS field, but I will do my best. I think I've chosen not to sort of give a didactic lecture on, individual drugs, because you probably all know more than me about them. I want to talk about how we make comparisons between the medications that we have moving forward, what tools we have to do that, and potentially what treatment approaches we have going forward. So this is a treatment talk, so these are my disclaimers. This is the obligatory slide in all MS treatment talks, which is the amazing development of drugs over the past 24 years or so. A real ramping up of the medication options, but also I think quite interestingly, each new drug that comes out seems to have a different mechanism of action, and we've gone through all the work that's been happening with the understanding the immunological basis. Some of the newer medications are really amazingly targeted. And just to point out two things, that the two most recent medications, daclizumab and ocrelizumab, seem to have a treatment biomarker potential. So Mahtab mentioned the CD56 bright NK cell expansion with daclizumab therapy, and that's actually been shown in this study to potentially correlate with disease activity. But also ocrelizumab, the B-cell depleting agent, and potential biomarker of switched memory B cells. So this is a new sort of concept in MS treatment that we may be able to see if our treatment is working for the patients before they get a relapse or a lesion. How do we compare the plethora of MS treatments that we currently have? We need to think about how we measure their effectiveness. So we talk a lot about risk reduction and these two concepts of absolute versus relative risk reduction in the randomized controlled trials. A thing to say is that in a clinical trial that you have a lot of clinical activity, a lot of events, an effective drug is going to give you a significant absolute risk reduction more than a relative risk reduction, whereas in a population that has less events, you're going to get a potentially less absolute risk reduction, but more of a relative risk reduction. And so how do we compare between studies? If you take this example here, one might argue that drug Z here has had a very good risk reduction in relapse rate in a cohort that has very few relapses. So that's a difficult cohort to treat because they have less relapses, and so this drug's done very well and potentially is superior. However, you also might argue that drug X has been trialled in a patient which obviously has more aggressive disease. So these patients had almost double the relapse rates of those patients in the placebo arm. And so is this drug better, seeing as it had a similar absolute risk reduction in an obviously more aggressive sub-cohort of patients? And I think in reality you can't actually say either. We need to realise that the populations in each study are unique, and to compare in between the studies is extremely difficult. But people try, and this is a current example of a study looking at the oral agents, so dimethyl fumarate, fingolimod, teriflunomide, and looking at all the phase 3 randomised controlled trials and putting together a somewhat meta-analysis in the studies that could be analysed that way. And if we look at the trial designs, they all seem to be pretty comparable. So they're all phase 3 randomised placebo-controlled trials. They all have a similar duration of treatment of about 2 years. They all have similar primary endpoints. There were a few differences between the trials. So in the teriflunomide trials, they did include a small portion of people who had progressive disease. In the Freedoms 2 trial, in fingolimod, there were patients that were previously on a disease-modifying therapy. Otherwise, these were relatively naive patients. So if we have a look at the outcome, and sorry it's a bit small here, you can see, as we know, that they all had significant benefit and varied relative risk reduction, and I'll just graph it there for you. But what we can see is that the absolute risk reduction on all three drugs was about similar, so about 0.18 to 0.19, whereas the teriflunomide group had a relative risk reduction of only 34%, the other one's around 50%. Can we compare them? So we can see that in the teriflunomide cohort, they had more relapses. So is its less relative risk reduction a factor of having more aggressive patients, or is it that teriflunomide is not as good as the other two medications? I think it's very hard to tell. There's been other studies, and this study come out in 2016 by Mendes, who had a look at all the randomized controlled trials of all the disease-modifying therapies, did a very big systematic review and meta-analysis, put them all into the one tables, and had a look at the number needed to treat on a few different scales, but we'll focus on the annualized relapse rate. And their conclusion was that interferon beta 1a subcut with a number needed to treat of 3 had the most consistent benefit, and natalizumab had the best benefit of a number needed to treat of 2. But there's a bit of discordance in the literature here, because alemtuzumab therapy in this study showed a number needed to treat of 5 in comparison to interferon, which had a number needed to treat of 3. These two drugs have been directly compared in the CARE-MS2 trial, and we know that alemtuzumab is better. So there's discordance in this sort of analysis on our MS treatments. Why is this? It's the interferon benefit in this trial is probably driven by the fact that study populations have changed over time. So we know that since we've started doing trials in MS, that the placebo annualized relapse rates have dramatically decreased. So our patients are getting less relapses. And is that a function of the trials, or is it a function of real life? It's probably a function of trials. So lower relapse rates is most likely due to a lack of recruitment of highly active patients when we have effective therapies. We are probably more accurately able to determine relapses in more recent studies. We have improved our overall management of multiple sclerosis. Crucially, there's this change in diagnostic criteria. So with every change and advancement in diagnostic criteria, we seem to include more people with MS who are on the more benign level. So these patients are going to have less relapses. And a concerning feature is this removal of trial patients who develop a relapse on a trial. And so your event rates on trial are going to be reduced. We also know that placebo-controlled trials and active controlled trials differ in their population recruitment. More aggressive patients are probably going to be recruited to active controlled trials as opposed to placebo. So take-home message from me here is different populations can't be compared. And the other problem with randomized controlled trials are that we have a 24-month follow-up. The outcomes at 24 months have variable significance into long-term outcomes. And indeed, Thomas Kalinchik in 2015 suggested that the 3 to 6 month disability progression that we detect in trials probably overestimates long-term disability by about 30%, because there's a degree of disability improvement that is not seen in a 2-year trial. So you probably realise where this is all getting to. Can we look at population data? Can we look at large cohort studies to try and elucidate the benefits of each therapy? So we know that observational cohort data, studies definitely carry inherent bias and confounders, and that may offset the advantages of having such large amounts of patients. Statistical methods are used significantly in these registry data, and one that has come out more recently is this propensity score adjustment, and I'll have to read my definition of that because it's I always forget it, but It involves matching a treatment cohort to one or more comparator groups on the basis of similarities of the patients and paraclinical factors. So in MS, that means prognostic correlates like relapse rate, disability progression, how long the disease has been there for, number of previous treatments. And so what this allows to do is to have a pseudo sort of control for your study cohort, but it doesn't account for unmeasured confounding factors like randomization does. And that's the big clincher here. The other thing with propensity score adjustment is that score is made at baseline and is not usually adjusted through the time period of the cohort study, whereas marginal structure modelling is a similar technique that does change your propensity cohort as the trial continues. And of course, there's big problems and challenges in running very big data registries on quality assurance, standardization across different countries, different centres, and the regulation that goes into that. But if you can get that all right, and if we trust the modelling, then you do have the ability to follow, for longer follow-ups, have interesting outcomes and potentially more meaningful outcomes. So I'd like to give you some examples of some data registry studies that have come out in the last couple of years. This is a study looking at the treatment effectiveness of alemtuzumab with natalizumab, fingolimod and interferon. This is a randomized controlled trial that will never happen. And so the cohort study is what we have to go on. And what it did show is that alemtuzumab and natalizumab have similar effects on annualized relapse rate, but interestingly they found that natalizumab seems to have this benefit at 6 months confirmed disability improvement. So whether natalizumab has some sort of effect on being able to allow patients to improve their disability. Both alemtuzumab and natalizumab were better than fingolimod and interferon. Another interesting study is this one. So the goal of this study by Lizak, also in the MS-based cohort, was to look at the effectiveness of the high effective drugs, the low effective drugs and placebo on relatively advanced patients. So these are patients EDSS4 and EDSS6, and the question is, do high effective drugs improve patients who are already sort of in an advanced stage of MS? And they proved that this is the case. So in time from EDSS3 to 6, there was a significant benefit with the high efficacy drugs, but also in time from EDSS4 to 6, and also time from EDSS6 to 6.5. And so it suggests treatment of advanced MS patients who are relapsing with high effective drugs is beneficial. And then we can get some very interesting questions that are asked. And this is a very difficult trial to ever do, which is what to do after discontinuing natalizumab therapy. We know that people come off natalizumab for various reasons, one being JC virus positivity, and the risk of rebound disease in that cohort is very high, and it's troubling. So what to do with these patients? There's been 2 registry studies here. There's the Italian registry and the Swedish registry. The Italians looked at fingolimod versus the injectables and found that fingolimod was significantly better. Rituximab versus fingolimod in the Swedish studies was dramatically better. So we saw a 99% reduction of the risk of at least one gadolinium-enhancing lesion and 91% reduction in the risk of first relapse. So that's a very interesting question that is potentially answered with cohort studies. And then there's sort of the brave new world of personalised therapy and using large population data to actually predict your patient's benefit from each therapy. This is very interesting work. I'm not sure how it's going to, how quickly it's going to come into the clinic, but essentially it's using these propensity matched cohorts to put your patients in a group of other patients who have been before them and see how they'll go on each therapy. And so this is a paper by Thomas Kalinchik this year. And so the last concept I want to talk about today is about, we all know this paradigm of MS treatment, which is there is damage that occurs early and there is irreversible damage that occurs early. And so the idea of the earlier the treatment, the earlier escalation of treatment, potential benefit years down the track. And in thinking about that, there's always been this this question about escalation therapy versus induction therapy. Escalation therapy is really what we do currently. I think it's the standard of therapy throughout the world in MS centres at the moment, which is we start with low-risk treatments and we escalate when things fail. And the idea about this is to avoid unnecessary toxicity in a large percentage of patients, because we know that there will be a large percentage of patients that you don't need to necessarily escalate up to risky therapies with. But this approach also allows sort of tailoring of treatment to patients. The problem with it is that, as we said, drug choice is in part trial and error. We can have all the studies like this we want, but at the moment it's trial and error. And the time to no disease activity may be long when we're doing trial and error, and so the risk of irreversible damage accruing is real. We also have in the escalation therapy, treatments that we're going to give people for decades potentially, and so we have this idea of risk being a long-term exposure to these agents. This is in contrast to induction type therapy, and I'll say that the ideas around induction therapy, I think there are probably two. The initial idea of induction therapy was really on the like stem cell transplant, which was give a high effective, almost resetting of the immune system followed by a less risky maintenance therapy. That is not talked about very much, and there are certainly no clinical trials based on that approach. However, the other type of induction therapy is this pulsed immune reconstitution therapy. So we have a few of them, and I'll go through what they are. But the idea of induction therapy is really to control a rapidly controlled disease, to get to this NIDA in weeks to months, so minimise that time, and prevention of early irreversible damage. But what you then give off is a degree of irreversibility with these medications. Once you give them, you can't ungive them. And then this front loading of risk. So we're going to be treating a lot of patients with high risk treatments, and that risk is really in the first part of the disease. And we also have a different type of risk burden, especially with alemtuzumab and stem cell therapy, when we have an immune dysregulation and potential autoimmune conditions that develop. So we talk about this concept of fundamentally altering a dysregulated immune system and hitting the reset button. This is a fairly nebulous term because it's undefined how you measure that reset. But there's this also idea of what is potentially curative. The current induction regimes we have are alemtuzumab, cladribine, stem cell therapy, and potentially ocrelizumab. And this was brought out to me in the recent ECTRIMS conference about whether ocrelizumab could be used as this type of therapy. I'll just go through them quickly. So we know that the alemtuzumab cohorts from the CARE-MS trials has recently been published at 5-year follow-up, and after single 2-year course of alemtuzumab, we have lasting responses of annualized relapse rates. We have lasting responses of the percentage of patients having NIDA. We have lasting responses of brain atrophy rates. But the thing to say is that not everyone, this is not for everyone who's treated with alemtuzumab. And if you take out all the patients who received a different disease-modifying therapy, patients who needed redoses with alemtuzumab, the figure of the patients who are getting lasting results from single course is probably in the region of 50 to 58%. Cladribine, so the Clarity extension trial gives us some information about this, although the evidence isn't as strong, which is that, and you know, in all these extension trials, it gets all very complicated when people have gone from placebo to drug and drug to placebo, drug to drug. But there were 2 arms in this trial that went from drug to placebo, and the treatment was 2 years of cladribine therapy followed by 2 years of placebo. And then they followed these patients out to 36 months or beyond, and it seems that at around the 3-year mark, there's still lasting benefit from cladribine having been given early and then placebo after. So it certainly has an induction type mechanism. And then I've included ocrelizumab potentially here, which is, I mean, the reason that ocrelizumab could be an induction therapy is it has similar mechanism of action to alemtuzumab. You know, it cell lysis of your B cells. You have very low population and then a repopulation of your B cells over time. And this is the 3-year follow-up data of just the phase 2 trial of ocrelizumab, which showed that for patients who had drug at month 0, month 6, month 12, month 18, then following them after that for 18 months, there's still significant treatment effect with reduction in annualized relapse rates. So what are the questions outstanding for induction therapy? It really is sort of what determines our level of response after we give a therapy. When do we need to retreat, and how do we identify non-responders? This idea of how to reset or reprogram the immune system really is ill-defined. Who's going to benefit from these therapies? So is it only patients who have aggressive disease? Should it be rolled out to everyone? And what is the relevance of a peripheral immune resets for ongoing central immunological mechanisms? And this treatment concept of moving back and forward between maintenance therapies and pulsed sort of intermittent therapies. That's all I have. Thank you.
Thank you, Justin. Are there questions or Sue?
So if we look at the long-term observational studies that MS BASE has allowed us to do and some of the others, it's actually it can demonstrate quite significant differences in potency, say, of various therapies. The number needed to treat type analysis just doesn't seem to correlate with that. Do you think that something like NIDA, some of the NIDA rates might correlate a little bit better?
I think
so that we can, you know, there's something we can use.
Yeah, no, that's right. I mean, I've focused mainly on annualized relapse rates here, but there are lots, and it's hard to know whether that's even a long-term outcome of relevance. But yeah, certainly NIDA MRI studies probably show a greater increase of variability between the treatments, definitely. I think NIDA is probably the goal of long-term outcome.
Any other questions? Okay, just like to thank all the speakers then for this excellent session. Thank you.